Hi, my name is Christina Huff and I'm a student nurse at Cedar Crest College. My evidence-based poster as well as my paper was done on reducing ventilator-associated pneumonia. My PICO question was, for mechanically ventilated patients, does raising the head of the bed compared to a supine position decrease the risk of ventilator-associated pneumonia? I also am interested in this because my father was in the ICU last year and he did not acquire pneumonia, and it was mainly because the nurses had directly kept his bed above 30 degrees. Now, what is very important about head of bed elevation is that several studies demonstrated that when you do raise the head of the bed, that patients experience less incidence of VAP, which is ventilator-associated pneumonia. And ventilator-associated pneumonia is one of the highest and most costly associated pneumonias in the hospitals today. A matter of fact, there is a 40% incidence that all healthcare related pneumonia is related to VAP, as well as an estimated cost of $1.5 billion of healthcare costs annually. The search engines that I used for my question, I looked up on PubMed and CINAHL and Google Scholar as well as Google Search. And I used limitations with those, and what I did is I put in dates of 2007 to 2015, as well as free-fold text and articles that were used in the United States. I then was able to narrow all of those articles down to 3. And the 3 that I chose was McCoy et al., and that is a non-randomized 2-group study design. And the purpose of that study was to make changes in the ED to see if they can decrease the incidence of VAP. The article discussed about how the changes that they were able to make was taken out of just using head of bed elevation as well as some other related related measures, that they were able to just do it in the emergency department as well. And what they have shown is that when the patient moved from the emergency department to ICU, the incidence actually decreased by 83%. Now, this article also used a VAP bundle, is what they call it, and it included not just head bed elevation, but it also included oral care as well as endotracheal tubing suctioning. So they also used 2 other things besides head of bed. Now, the next article is going to be Wigerman et al., which is a randomized full factorial study. And the purpose of this study was to see about the impact of patient migration and torsal angles on the head of bed elevation when it was raised between 30 and 45 degrees. The results showed that when the head of bed was elevated to 30 to 45 degree articulations, that the patient actually migrated down in the bed towards the end of the bed, which then the patient went under the recommended level when they slid down. So the third article was also done by Wolkin, and that was a randomized prospective cohort study. And the purpose of that study was more or less to find out if continuous monitoring and using visual bedside monitors as well as audible alarms that would allow the nurses to adhere to going in to go check on the patient in regards to head of bed elevation being above 30 degrees. So the results were real-time continuous monitoring and audible alarms that went off when the patient slid down, and it was a feasible intervention, and it improved head of bed elevation adherence by 2 to 3-fold. And the other exam that they did was whether intermittent checks of the head of bed elevation by nurses were accurate, and the results actually showed that the nurses overestimated by 25%. So they thought that they were doing it correctly. So with these 3 articles, there were roughly 4 recommendations. And the 4 recommendations were head to bed elevation should at least be 30 degrees, and that all nurses should be trained on halibed and by intubated patients. That was by McCoy. The patient migration should be controlled to maintain proper torsal angle and adherence, and that was done by Wigerman. And visual displays and audible alarms definitely should be used, and that is by Wolken. So all of those do help prevent VAP. Also, my conclusion is during this research, the incidence and appraisal of VAP, it became clear that even though head to bed is effective in reducing VAP, there are several factors that head to bed also need to include. So thank you very much for watching this. Bye.